Tuberculosis, scientific name, Mycobacterium tuberculosis. Tuberculosis, we've all kind of heard of tuberculosis. It's a bacteria that does affect the lungs. It can also affect other parts of the body. This was something that I actually learned by doing this presentation. It can affect areas such as skin, the bones, the gastrointestinal tract, the lymph system. It just affects so many different things. This is a really strong bacteria. We associate it mostly with the lungs because that's where most cases are found. And it does like the lungs because the lungs have a really good blood supply. The lungs have a high level of carbon dioxide because we are breathing in oxygen and breathing out that carbon dioxide. So it has a supply of oxygen and blood and carbon dioxide, so it makes for a perfect environment for this bacteria. Where can we find TB? TB, for it, humans are the only reservoir. But TB microbiome can also be found in other places. It can be found in soil in some waters. It can also be ingested by drinking like unpasteurized milk. So we wonder like how it gets to other parts of the bodies, like the GI tract, for example. If we do ingest milk that does have those TB microbiome, it's not going to go to our lungs because what we put into our mouth and swallow does not go to our lungs. It goes down the GI tract. So this is how we can contract tuberculosis and it go to other parts of the bodies. That's an example. The spores can survive weeks to months in fabrics such as carpets, linens, couches that are cloth, anything like that. So, and TB can survive months in an infected person's sputum. So, we just have to be careful around infected people, make sure that they're getting that treatment and things, and we'll touch on that in just a second. What does tuberculosis look like? They are thin and they're slightly curved or straight shaped bacilli. And if I can get my pointer here, this down here, this bottom picture here, you can see how like this one right here is straight. However, this one right here is a little bit curved. So they can be straight or slightly curved, but they are thin, rod-shaped bacilli. It's bacilli that is non-motile, it's non-sporing, it's non-capsuled. Its acid base is neither gram-positive or gram-negative, and bacteria can appear as single, pairs, or clumps. So this is like a clump right here that we have in this slide. And if you can tell up here on the top picture, it is an x-ray, and on this x-ray, we've got a clump here. We also have a clump here, and it looks like we may have a clump that's developing over here. Are there different types of tuberculosis? There are different types of tuberculosis. There's like our regular old tuberculosis that we can treat. We can do, a higher course of antibiotics that will get rid of that bacteria. However, there is bacteria, the type of tuberculosis, the bacterium, is developed a resistance to like our regular antibiotics and that are used to treat tuberculosis, and they're not going to do that anymore. So medication drug resistant tuberculosis, MDR-TB. The number one cause of MDR-TB is inappropriate tuberculosis treatment. So for example, we all have been known to do this, I'm sure, at some point, but most of us have. We'll have strep throat, for example, and they give us amoxicillin. We start to feel better. What do we do with the rest of the amoxicillin? We put it up and say we might need that later, but we're feeling better, so we don't think we need it anymore. Same thing with tuberculosis. You have to finish that treatment. The next one is a little bit more drug resistant, and it's called extreme drug resistant, XDR tuberculosis. It is a more severe form of MDR. This one is really rare. And this form of tuberculosis means that you've tried at least 4 anti-tuberculin drugs with no prevail. And the XDR-TB also means that someone is resistant to 2 of the newest tuberculin medications. So you are resistant to 2 of the newest ones, and you've tried at least 4. So that's 6 different medications. So that would be extreme drug-resistant tuberculosis. How do we get TB? We talked about that. An example a while ago is if we get like tuberculosis in the GI tract, how that can happen by unpasteurized milk. But when we're talking about tuberculosis in general, that goes into our lungs, which is the most common form of tuberculosis. It is spread when droplets of an infected person go through the air and are inhaled by another person. So if I have a person standing right here on top of me, and sometimes it's accidental, and I know we can't get it, but like we cough, or it's just all of a sudden we can't cover our mouths, that person could infect me, because with this droplets this close, I'm going to be inhaling in some of those droplets. And it's not just coughing, it can be coughing, sneezing, anything of that sort. However, there are some myths about tuberculosis. Kissing, shaking hands, eating after one another are ways that TB is not spread. It is usually spread when it comes from that intense deep cough or a sneeze or something with the lung tract, not just sputum in the mouth. So kissing, eating, drinking after one another, those are not ways to get tuberculosis. Okay, symptoms of TB. The latent phase is the first phase of TB. Okay. Symptoms are probably going to be nothing. They usually are nothing. So I could be sitting right here, right now, not have any symptoms at all and have tuberculosis, but I'm in the latent phase. Some people may experience a little bit of fatigue, a little bit of low-grade fever, a little slight cough, potentially things that we can just rub off as allergies. During this time, though, TB cannot be spread from one person to the next. This is continued symptoms. When a person's immune system has done all it can do to fight off the infection, but it is still there, this phase is known as the active tuberculosis disease phase. Symptoms with this phase are not usually severe, but they do worsen over time. So we might start out with, like I said, a little slight, little something, like a little tickle in our throat, and it might progress to a really deep, severe cough. But that may be over a 1 to 2 week span. Symptoms with active tuberculosis include chest pain, cough, possible bloody cough, chills, weight loss, and fatigue. The most common symptom of active tuberculosis is a persistent cough that lasts longer than 3 weeks. Pain in the chest region, coughing up blood or blood-tinged sputum. So if we cough and we cough up something and it's got a little bloody tinge, that is warning signs that we possibly may need to go get checked for TB. Who is at the greatest risk for getting tuberculosis? Well, of course, your substance abusers weaken their immune systems and they're more prone to a lot of things. Diabetes, also, patients with low body weight, patients with head or neck cancers, organ transplants, all these things that kind of make us a little bit more immunocompromised. I did not know this one, but specialized treatments for rheumatoid arthritis or Crohn's disease can also have you as a higher risk. However, HIV patients are 16% more likely to contract tuberculosis than any other patients. And tuberculosis is the most common cause of death for HIV infected patients. However, if you look at the major majority of HIV patients, which is like your highest population is like Africa, for example, other countries, their tuberculosis rates are a lot higher as well. So if you have a country that has a high HIV rate with a high tuberculosis rate, I can see how 16% are more likely to contract tuberculosis than any other patients, and those are the patients with HIV. How do we determine if we have tuberculosis? Well, first off, if you think that you may have any symptom of tuberculosis, you should get checked. And secondly, if you've been exposed to anyone that has had TB, you would need to get checked. So anytime that at all that you think that you may have come in contact or been exposed or know for sure you've been exposed, you probably need to get checked. But how do we determine it? Of course, we are all familiar probably with that skin test, especially in the medical field. We have to have a TB test to be able to do clinicals. The TB test is just given just right underneath of the skin. It's usually on the forearm, makes a little wheal, like right here on the back of the forearm, like right up in this area, in the soft tissue on the forearm. It makes a little wheal. The wheal is looked at within 48 to 72 hours, no less than 24, no longer than 72. That test will, if it is a positive test, it will become red and inflamed, swollen. Any of those type of things we consider as positive. There's sputum tests, there's also x-rays, and the most molecular testing techniques is the PCR testing. Dr. Robert Koch discovered the tuberculosis bacteria on March the 24th, 1882. In 1834, the medical term tuberculosis was originated, though the bacteria had not yet been discovered. They actually already had gave it a name. Some of the names, though, in the past include wasting disease, the white plague, consumption, because most of the time you just kind of withered away. There was a history of tuberculosis sanitariums that were set up for people in the 19th century, and it was believed that if you had adequate food, fresh air, things like that, that this would heal you from this disease. Of course, maybe some did, but probably not a lot. And these were usually put into rural areas where, they could get the fresh air, the quietness. They could provide them good meals and things for their bodies to heal, and they thought that they were helping them and that this was a good cure for them. Okay, 100 years ago, everything's prognosis was a lot less than what it is today. We had just got the discovery of penicillin, in the 1900s, 1940s, 50s region. Until then, we didn't have any forms of to cure tuberculosis, but now in today's world, the mortality rate is very low. But if left untreated, and we're going back to these countries where they don't have good medical, they can't just go to the hospital, or they may not have doctors, or may not be able to get antibiotics and those type of things. The prognosis is greater than 50% will die. So here in America, like I said, it's different. We can just run down to the local ER or to our physician, get those antibiotics, get treated. We have so much more options, but this is going back to our undeveloped countries and things like that, that is greater than 50% in those areas. Stopping the spread, of course, anytime that you sneeze or cough or anything, you want to be able to cover your mouth, make sure we're washing our hands, those type of things. In the hospital setting, you will be put in an isolation room. Nurses and staff that come in contact with you will be required to wear a fitted respirator. It's just not a regular surgical mask. When you are hired to the hospital, they do fit you for a respirator that is made specifically for tuberculosis patients, in case you ever come in contact with one. Some interesting tuberculosis facts. Famous people who succumbed to the disease include Eleanor Roosevelt and Nelson Mandela. And the stethoscope that we use today, along with x-ray equipment, were both used in diagnosing tuberculosis, and they were both invented by doctors that were treating tuberculosis. And those are the doctors that I've mentioned in the slide. So tuberculosis does have a rich history. We have a great potential to take care of it now. It is a very curable disease now. And I hope that you found this report very interesting.